Hello, Dr. Arif. How are you?
Hello, I'm fine.
Yeah, it's very good. It's nice to see you again.
Yeah, nice to meet you
Yeah.
again.
What about this event, this crisis, COVID-19 in Jakarta?
Yes, it's still increasing now.
Increasing.
Yeah.
Oh, it's bad.
Still.
It's bad. I think in Egypt it's much better. We little bit reopened a lot of clinics, hospitals, less of patients. I think
Yes.
soon to be zero COVID-19. I hope it. So I hope all this crisis and this I think virus, this a bad thing all over I face. Everything it will be better to join you in Egypt soon, inshallah. So I will introduce you, dear Professor Arif, to start. Professor Dr. Arif, one of the best in musculoskeletal sonography and musculoskeletal rehabilitation. He is a medical director and consultant in physical medicine and rehabilitation, Jakarta, Flex Free Musculoskeletal Rehabilitation Clinic. Also, he is one of the unique one that did a lot of research and a lot of presentations in these topics. So today, in these episodes, we are talking about ultrasonography of the Achilles tendon pathology, which is, I think, it's very interesting. I have in my office about 4 cases, tendon Achilles, different pathologists, tendinosis after complete tear repair. A lot of these cases we are facing today. So please, Dr. Arif, you can start this stage for you. Yeah.
Okay.
Okay.
Thank you very much, Professor. Yeah, today I will I will share about the ultrasound pathology of the Achilles tendon. Uh, I believe that all colleagues already known about the Achilles tendon and many cases of Achilles tendon in our daily clinical practice. So today I will share about the ultrasound pathology of the Achilles tendon. Yes, Achilles tendon pathology is rarely reported out before 1950, and the incidence of Achilles tendon pathology in industrialized nation is approximately 7 per 100,000 per year, and the mean age 36, and male predominance, and left more than right for unknown reasons. And the etiology of Achilles tendon rupture could be due to repetitive trauma with collagen degeneration, also local steroid injection, oral corticosteroids, fluoroquinolones, inflammatory and autoimmune condition, collagen abnormalities and neurological condition, and also could be due to violent muscular strain in healthy tendon. So what is the spectrum of the Achilles tendon disorder and overuse injuries? It could be range from inflammation of the peritendinous tissue or peritendinitis, paratendinitis, and degeneration of the tendon or tendinosis. Tendon rupture could be partial or complete, and insertional disorders, which could be retrocalcaneal bursitis and insertional tendinopathy. Is all the spectrum of the Achilles tendon disorder and overuse injuries. And when we talk about the clinical findings, clinical terminology is variable and distinction between different pathology and difficult clinically. And in general term, we could use the achillodynia for pain in the region of Achilles tendon. We can see here from the history, clinical finding, what is the difference between paratendinopathy, tendinosis, partial rupture, insertional disorders, anomalous soleus, and complete rupture. And what about the peritendinitis? Peritendinitis is inflammation of peritoneum. We know that the Achilles tendon doesn't have tendon sheath. It only has the peritendon. And peritendinitis is inflammation of peritoneum, often represent first symptomatic stage of Achilles pathology. Isolated peritendinitis, usually the tendon itself is normal, and there is adhesion from between peritendon and Achilles. And paratendinitis is inflammation about the Achilles tendon, and we can see the edema within Kager's fat pad anterior to the Achilles tendon, and it can be seen in asymptomatic patient. And this is the tendinosis. And how about the tendinosis? Is this most common Achilles tendon pathology? Tendinosis, we can know the tendinosis, there is a degeneration with no significant inflammation. So we call it tendinosis, not tendinitis. There is a hypoxic or fibromatous degeneration, could be myxoid, lipoid degeneration, and tendinosis also could be present with the calcific, with calcium pyrophosphate, and also could be accompanied by peritendinitis. And this is the ultrasound appearance of the tendinosis. And we know that the ultrasound appearance of the tendinosis is similar with all tendon. First, we can see there's disruption of the fibrillar pattern of the tendon. And then we can also see hypoechoics within the tendon. And then we can see also the increase of the vascularity of the tendon, which could be shown by the positive power Doppler. And the hallmark of the typical appearance of the Achilles tendinosis is there is a fusiform swelling of the Achilles tendon. You can see here in the right screen picture, the ultrasound picture in the right screen. This is the long axis and this is the short axis. You can see the fusiform swelling of the tendon. This is the typical appearance of Achilles tendinosis. And in the Achilles tendinosis, we can also see the increased Kager fat pad echokinicity. You can see here below the Achilles tendon, there is a Kager's fat pad. There will be an increased echogenicity in the Kager fat pad here. And then there are paratenon thickening also here. And we can also see there is a fluid collection here in the retrocalcaneal bursa. That's the hallmark of the Achilles tendinosis with the ultrasound. And here is another example of the Achilles tendinosis with the calcified, with the calcification, intratendon calcification here. You can see hyperechoic dot here as a calcification, intratendinous calcification here. It's very painful usually. And another spectrum of Achilles tendon pathology is the partial and complete tendon tears. The spectrum, there's a micro tears, interstitial tears, partial tears, or complete tears. And the most common site is 3 to 4 centimeter proximal to insertion. Partial tears often lateral, and there is discontinuity of fibers, heterogeneous echo textures, and there is intratendinous gap. Now, how about the partial tendon tears here? Partial thickness tear, probably better term as focal tendinopathy, because sometimes we difficult to differentiate between the partial tendon tears with the focal tendinopathy with the ultrasound. And there is tendon thickening more than 10 to 15 millimeter in the antero-posterior dimension. There is abnormal intratendinous echo texture and a clear discontinuity in one portion of the tendon fibers while other fibers remain intact. There is interstitial defects within the tendon, such as hypo or anechoic cleft area, localized tightening, contour abnormality, and there is peritendinous fluid, localized increased blood flow. And the most important here, we should always perform the dynamic ultrasound assessment. In the partial tears should demonstrate the gliding of a partially torn tendon as a single unit rather than the separation of tendon and seen in complete tears. We can see from the video here, I will show you the video about the partial and the complete tear here. This is the partial tendon tears with the panoramic scan. We can see the proximal tendon and distal tendon here. And this is the long axis, and this is the short axis scan. And in the right screen here, we can see the partial thickness tear with the intratendinous calcification. This is very difficult to differentiate sometimes because the intratendinous calcification will produce the acoustic shadowing. So sometimes it's difficult to differentiate whether this is the partial thickness tear or just the calcification appearance in the ultrasound. So we should do the dynamic examination. And then how about the complete or full thickness tendon tears here? The complete focal disruption, there is complete focal discontinuity of tendon fibers. Tendon retraction, we can see the two ends of the torn tendons are retracted and a gap is created between them. Into the aforementioned gap, there may be herniation of the cage, and in acute phase, we can see the fluid collection in the gap, and we can do the compression with the probe. And later, we can see also in the chronic, there is a fibrous scar tissue in the chronic heel tear, and also there is a posterior acoustic shadowing from the torn tendons. It's called a reflection artifact. Visualization of the plantaris tendon. Sometimes you can see plantaris tendon in the complete tendon tear. An intact plantaris tendon may move into an Achilles tendon defect and making it more easily visualized in a complete tear. The most important here is we should do the dynamic ultrasound assessment here. This is the complete or full thickness tears here. We can see the stump, the stump of the tendon here. This is the proximal and this is the distal. And this is the patient here. We can see from the physical examination, from the inspection, we can see there is a gap here in the Achilles tendon. And this is the video we can see with the dynamic examination. We can see the proximal and distal stump here, and there is a fluid collection, which is the hematoma here. This is the acute Achilles complete or full thickness tendon tear. And another spectrum of the Achilles tendon pathology is the muscle atrophy. In the acute atrophy, we can see the diffuse edema throughout muscle belly, and there is also visually we can see if we see the muscle atrophy, this will be the prognostic factor for the surgery. And in the irreversible atrophy, we can see fatty infiltration here. And atrophy usually occurs first in the soleus, and in the sagittal image should include at least 3 centimeters of distal soleus belly. And atrophy of the gastrocnemius is rare than the soleus. Okay, and another spectrum of the Achilles tendon pathology is the associated osseous abnormalities we can see here. The most common associated osseous abnormality is enthesopathy. There is a distal ossification from previous partial tear, may mimic a fracture of enthesophyte. And there could be retrocalcaneal bursitis, reactive edema at Achilles insertion, degenerative cystic change at inferior Achilles insertion here. There is an intratendinous of the Achilles tendon near the insertion in the calcaneal.
I think you have, dear Professor Dr. Arif, I think a problem in connection. Sorry for that. I will join us again soon. Yeah, yeah. I think there is a problem in connection. Yeah. You hear me, Dr. Arif? Dr. Arif? The sound, I think we have a problem in your sound, Dr. Arif.
Can you hear me?
Yeah, yeah. Now, yeah, it's good. Excellent now. Yeah, you can start.
Okay.
Okay.
Okay. Okay. Now another insertion pathology here is the antipsychotic. You can see here the antipsychotic. There is an Achilles thickening, and usually in the older, less athletic, overweight individual or older athletes, as a you can see here for the lateral photograph of the calcaneus here, there is a bone formation here in the calcaneus. And here is the ultrasound picture of the calcaneal endocephalite in a long distance runner with chronic heel pain. Here we can see the bone formation here, the red arrow here, and also there's a swelling of the Achilles tendon here, and also there's a fluid collection in the retrocalcaneal fossa here. That's the appearance of the antipsychotic of the insertional Achilles tendon. And another insertional Achilles tendinosis here, you can see here, there is swelling of the Achilles tendon here, hypoechoic, intratendinous hypoechoic with the calcification here. This is the long axis, and this is the short axis. And this is another case of insertional Achilles tendinosis here. You can see the swelling of the Achilles tendon near the insertion here, and this is the panoramic view of the Achilles tendon here, and we can see the positive power Doppler here. And the most important here when we have the insertional Achilles tendinosis here, we should notice that not always have a positive Doppler here. Sometimes the Doppler here maybe could be negative here. And another spectrum of Achilles Achilles tendon pathology here is the myotendinous junction injury. And the most commonly is the medial head of gastrocnemius of dominant leg. There's a focal fluid at muscular tendinous junction, which follow distal muscle belly and U-shape on coronal image, and more commonly partial and adjacent muscle edema due to strain or acute atrophy, and adjacent hematoma should be noted, and this may be surgically evacuated. And if there is complete tears, it should be treated surgically. And how to differentiate? We should perform the dynamic examination. This is the case of tennis leg here. There's a rupture of the medial head of the gastrocnemius with the intact soleus muscle here. And usually the patient come with the pain on the calf muscle here, sudden painful, like there's someone hit their calf muscle here, and sometimes the patient could hear the sounds of pop here. And when we scan with the ultrasound, we can see here there is a hematome here, there is a fluid collection here, and this is the dynamic video of the tennis leg. We can see here. We do with the dynamic scan here, we can press our probe here to see the fluid here. This is the acute injury here. This is the hematome here, the blood here. You can press. And we also can do the dynamic with the plantar and dorsiflexion as well. And we can use the ultrasound to follow up the tennis leg after the treatment we give to the patient. This is the 4 months post-treatment here. You can see there is no hematome here, and there is a hyperechoic, or here is a fibrous tissue here. So this is 4 months post-treatment, and the soleus is still intact. Okay, and another Achilles tendon pathology is the retrocalcaneal bursitis. In retrocalcaneal bursitis, there's hypertrophy and inflammation of the synovial lining, and associated with the Achilles pathology or inflammatory arthropathy. So the retrocalcaneal bursitis could be primary or could be secondary because of the inflammatory arthritis. So this is very important here. If we have the patient with the retrocalcaneal bursitis, we should have to rule out whether this is due to inflammatory arthritis or just only retrocalcaneal bursitis. And no patient had tendinopathy without retrocalcaneal bursitis. If we have the Achilles tendinopathy, there must be a retrocalcaneal bursitis, or there must be fluid collection inside the retrocalcaneal bursa. So usually we can differentiate between the primary retrocalcaneal bursitis with the inflammatory arthritis. When the retrocalcaneal bursitis is due to the inflammatory arthritis, we can find the positive Doppler inside the retrocalcaneal bursa here. And when the retrocalcaneal bursitis is not due to the inflammatory arthritis, usually due to the Achilles tendinosis, usually the power Doppler here is not positive inside the retrocalcaneal bursa here. And this is the short axis of the retrocalcaneal bursitis with the Achilles tendinosis. You can see here the retrocalcaneal bursa, the power Doppler was negative. This is so we also have to perform the dynamic evaluation in the retrocalcaneal bursitis. We can see the fluid here with the dorsiflexion and plantar flexion of the ankle. We can see here the fluid here. The fluid is a content of the hyaluronic acid here, or in the normal condition, but in the inflammatory condition, this is the inflammatory fluid here. We can see with the dynamic examination as well here. Okay, and another spectrum of the Achilles tendon pathology is the Haglund's deformity. It's also called pump bumps, or because of steel heel counter compressed posterior soft tissue against the posterior superior calcaneal. Usually in the elder people, we can see here there is swelling in the Achilles tendon here, and there is a triad of thickening of the distal Achilles tendon. There is a triad for the Haglund deformity here, thickening of the distal Achilles tendon, and the retroachilles bursitis here, just above the Achilles tendon, and also there's a retrocalcaneal bursitis. So when we scan with the ultrasound, we found the triad here. The diagnosis should be the Haglund's deformity. And another spectrum of the Achilles tendon pathology is the xanthomas of the Achilles tendon. Achilles tendon is focally or diffusely infiltrated by lipid due to hyperlipidemia or hypercholesterolemia, and usually the Achilles tendon could be normal or enlarged and can mimic tendinosis or partial tears, and were usually also very painful. And this is the ultrasound guided intervention of the Achilles tendon. We can do the ultrasound guided for the Achilles tendon with many injectants, but I usually use with the regenerative injectants. And the most important when we do the intervention or injection of the Achilles tendon is never inject the tendon with the corticosteroids, because the Achilles tendon doesn't have the tendon seat, and it will make the Achilles tendon rupture after the injection. So when we do the ultrasound guided intervention, we can do with the out of plane here, like this. This one is the ultrasound guided retrocalcaneal bursitis, aspiration and injection. And we can do with the long axis scan in plane approach. This is the ultrasound guided hyaluronic acid injection. I just inject not into the tendon, but just peritendon here. So thank you. That's all my talk about the ultrasound of the Achilles tendon pathology.
Okay, I think I would thank you, dear brother Dr. Arif, for this interesting presentation as usual. So I can ask the first question, but please, any one of the attendees, I think it's very interesting to collect a lot of attendees here in Zoom and in Facebook group. So any questions, please put it in Q&A box. So in complete full thickness tear of the Achilles tendon after repair, what about the ultrasound follow-up schedules to be sure that we can do a weight pair for this patient? Hey, Dr. Arif?
Okay. Okay. I usually follow up the
After repair.
patient. I usually follow up the patient after the Achilles tendon repair surgery. Usually, I follow up 1 week and then every 2 weeks
Yeah.
for 3 months. Yeah.
Yeah. Second questions, what about the incidence for re-injury or rupture again after repair? I think it's almost most of patients that done repair does not regain for all full activities, especially in springing and etc. So can you suggest the percent of recurrency for this ruptured tendon Achilles?
Yes. In my experience, I just found one patient with the re-rupture after the surgery, and after 2 months, 2 months after the surgery, there's a re-rupture of the Achilles tendon. I just found one patient,
Okay.
and
That's great. I think it's depend on the surgeon itself. I think, yeah, yeah.
yeah,
Yeah. So you prefer to start with the tendinosis with BRP or hyaluronic injection?
yes. Uh, I usually use the regenerative injectant like PRP, hyaluronic acid, or prolotherapy to treat the Achilles tendon pathology. It depends on the cause usually.
Yeah.
For example, I will use the PRP for the Achilles tendinosis, and then if there is a retrocalcaneal bursitis due to the inflammatory arthritis, I will use the triamcinolone. I will use the corticosteroid, but not into the tendon, but I will inject into the retrocalcaneal bursa. And then, um, if the patient can afford the PRP, because the PRP is expensive, we use the PRP. But if the patient could not afford it, the PRP, I use the dextrose for the Achilles tendinosis, and for for the for the uh, insertional or non-insertional tendinosis as well. But for the Achilles tendon rupture, I usually combine the hyaluronic acid with the PRP.
So what about extracorporeal shock, shock wave?
Yes, of course. Where I usually also will give the patient choice to choose the treatment option. For the non-interventional, I will give the shock wave, but sometimes the patients say, sometimes the compliance of the patient is not good. So patients say, I can come to your clinic once a week for the shock wave.
Yeah.
Just give me the injection. Okay, I will give the injection.
Yeah. Oh. Another question from Kenneth. He said, great lecture. What intervention do you do for calcific tendinopathy of Achilles tendon?
Okay. Yes, for the calcific tendinopathy, usually in the Achilles tendon, the calcification is the type 1 calcification is also is impossible to aspirate the calcification. So when there's a calcific tendinopathy in the Achilles tendon, I will use either the shockwave or the PRP.
Yeah, great. Okay, I think no more questions. So thank you again, dear brother Dr. Arif, for this valuable time and this amazing talk as usual. Thank you. We hope to see you soon in Egypt, visiting Egypt and attend our conference in the.
Okay.
Okay, okay. See you. Bye bye.
Thank you very much, Professor. Bye bye.